So welcome all of you. We are 10 minutes behind schedule. So I would start the meeting, and we don't have one speaker, the antimicrobiological treatment. Dr. Menaka is not there, and the time is allotted to Dr. Basab Ghosh, who's come from Tripura. So we have the speakers, Dr. Senthil, who's a very senior plastic surgeon and a diabetic foot surgeon from MB Diabetes Center, Raipuram. We have Dr. Ravi Kumar, who will be introduced Tamburan Vascular Center and our center, who will also be talking on the what to do in the blood vessel is compromised, blood circulation is compromised. And then we have Basab Ghosh, who's a senior diabetologist from Tripura. Stand up, Basab. No, stand up. So he will be talking on offloading and rehabilitation, which is also important. It's not just cutting off the leg, but what to do after that will be talked about by Basab Ghosh. I'll be talking to you for 3 minutes. It's a 3-minute foot examination. So it should be 3 minutes, no? So 3 minutes. First, second slide. Second slide. Oh, here. Oh, I'm sorry. So the patient history should take 1 minute. Okay. So it's a 3-minute foot examination. This is what we used in the RSSDI Save the Feet campaign, which we published in BMJ. I'll show you in the end. We published this data, and in 1 minute, the slide is not coming on. So we ask the history of the most important. If you forget everything, ask only one history point. Have you had a amputation before? Have you had a foot ulcer before? It's not coming. It's okay. Physical examination is 1 minute again. So it's history taking 1 minute. Second minute is physical exam. This has been published by Andrew Bolton and David Armstrong. I can't give you the reference now, but it's been published data, 3-minute foot examination. So it's not invented by me. So what to teach in 1 minute? So that is also part of this procedure. And this questionnaire we used during the RSD. So it's validated in India in 50,000 patients. So in 50,000 patients we validated it. So it's beautiful validation. And the classification of the feet at high risk feet, we used, it's not coming, we used the IWGDF classification of high risk, low risk, very high risk, and so on. It's not coming, the slide is not coming. I don't know what happened. And we finally published this data in BMJ. So this is another validation. So we called it RSD, National RSDI's Save the Feet and Keep Walking campaign in India. And we did 50,000 patients from all over India. And this was published in BMJ about 2 weeks ago. And my colleague, Dr. Aruchelvi, I don't know whether she's there, and Dr. Satyavani and all my other team members took part in this study. Can I show the next set of slides? That's another 3 minutes. So I'm going outside the foot examination, 3-minute foot examination. And many of you have gadgets which I'm going to show you. The first sensation to be lost is the small fiber, according to Dan Ziegler from Dusseldorf. So you should test, it's been validated. It's made in Chennai by 2 companies. You have a sensitometer to measure the temperature. If you don't have, can you show Bamila or Sina? If you don't have, you can use a tip therm, which has got a metallic end and a wooden end. In an air-conditioned room like this, you can see the difference. There's a beaker of water you can use. Yeah, you can touch, and only thing is you should keep your eyes closed. But this is what we use, and Sina uses it extensively, and Sina and Pamela are our podiatry. I forgot to welcome you both. So they have finished podiatry from MGR, Dr. MGR, Tamil Nadu Dr. MGR Medical University. They are the two only Tamil Nadu podiatry assistants, so as to say. So don't forget to measure the temperature perception for small nerve fibers. The vibration perception threshold, if you have the machine, we have validated it years ago, and it has been validated in India. It has been validated by Andrew Bolton. And if you have the vibrometer? No, okay. So you can show the, if you don't have it, you can use a 125 hertz tuning fork, 256 for hearing, and 125 is for the thing. If you have access to the Rydell Cipher tuning fork, you can use it. It's available in the United Kingdom, and we have validated this against the Biotis meter. This is for the large nerve fiber. So you can use the 125. This is also a 128 hertz tuning fork, and you have graduations up here, and you can do it. Bamila, next you can show I'll finish in another 1 minute. The handheld Doppler, you have the handheld Doppler here? Is a quick device. It's available in Chennai, and you can see you will hear more about it from Dr. Ravi Kumar, but this is a simple clinician's tool, physician's tool, clinician's tool. Can you hear the triphasic sound? It's over the radial artery, no? So you can use it for diagnosing it instantaneously. So when you have a patient, you should examine for the handheld Doppler, using the handheld Doppler, and you should use the small fiber and the large fiber. You should test for neuropathy, loss of protective sensation with this, and also use a handheld Doppler. Now, in the last 30 seconds, I will tell you about a study which Mike Edmonds showed. Why am I involving the surgeons, the interventional radiologists, the podiatrists, diploma podiatry, the research person, Dr. Divya Bharati in epidemiology, who's an epidemiologist. She's why this team? This in 1986. This is a publication in 1986 by Mike Edmonds, who retired from King's College in London. So what he showed was, if you have a multidisciplinary team, you can save the feet. If you have a multidisciplinary team, Peter Watkins was also a part of this paper. He retired. Mike Edmonds is retired. The King's College was run by them, literally. So Mike Edmonds is retired. Peter Watkins is retired. I don't know whether he's alive also. Now, this is a classic example. This lady from Erode was asked to cut the leg, but this is affecting the ankle joint. So see what we did. We first debrided the wound, left ankle. There was a necrotizing fasciitis. We give antibiotics covering MRSA and gram-negative, gram-positive, and anaerobes, so on. We have to give it. And we did a debridement. After wound debridement, we did a bypass. At that time, Ravi Kumar wasn't there, so we had only the vascular surgeon. We did the left superficial femoral artery to left distal popliteal, and synthetic graft was used. It's cheaper. I don't know why it's cheaper than the balloons in India, because the balloons are not yet capped by the government of India. It's cheaper. Then we got the orthopedic surgeon in. So we had a plastic surgeon who debrided. We had a vascular surgeon. We had an orthopedic surgeon who put the fixator. And this is what we have done many cases like this before. I'm just showing you one. I have finished the last slide. And finally, the plastic surgeon came in and he put a skin graft. Podiatric surgeon came, diabetic foot surgeon came, Dr. Senthil, you did the case, no? Yeah. So I think 2 feet are given by God for a purpose. And we should use these 2 feet, we should protect the 2 feet. And we should go to the graveyard with 2 feet, not with 1 foot and one artificial foot. Anyway, we go into the chamber, 800 degrees chamber. We all have to go. Or in the bricks, they keep bricks over us and they burn us. Or you are buried forever. But you should go to the graveyard with once you have to visit the graveyard, and that's a final visit. So you have to go with 2 legs, not with 1 leg. So that's my last slide. Thank you very much. And next is Senthil. I don't have the program. Yeah. So Amarnath is going to talk on radiology. So I didn't introduce him. You'll introduce yourself? Yeah. Dr. Amarnath is giving a talk in API day tomorrow. So I would introduce him formally at that time. Dr. Amarnath is a radiologist, no?
Yes, sir. Professor in Stanley Medical College.
Yeah. Professor of Radiology in Stanley Medical College.
Good morning. At the outset, I would like to thank the organizing committee, Shanmugam, and the team for giving me this opportunity. In the next 10 minutes, I'll quickly show some of the images, radiology, how to differentiate simple diabetic ulcer, or infected or neuropathic joint, and all this. You know the prevalence, around 25% of diabetic patients will have diabetic ulcer in their lifetime, and 70% has nervous involvement throughout their diabetic disease. And it may present with simple ulceration or maybe have a coexisting arterial disease or the nervous disease, sometimes neuropathy, and most of the time the arterial as well as the nervous disease coexist. And the very challenging for the radiology is when there is a neuropathy plus superadded infection. It is very difficult to differentiate these coexist. And we know the causes for the ulcer. I'm not going to go into the depth of the details how the ulcer is formed. The imaging modalities, what we do is the plain radiograph, which is commonly used to assess both neuropathic joint as well as the peripheral vascular calcifications. MR is the modality of choice to differentiate neuropathic joint as well as the infection, and CT may have a role, not so much. And ultrasound Doppler is the initial modality to see the peripheral arterial disease as well as the nerve involvement. And in doubtful cases, we do PET CT. So these are all the modalities what we do in diabetic foot. I will just show, this is the normal foot. The second one is the normal foot. You can see the torso-metatarsal joint. That is perfectly normal. The second one. The first one, you can see the peripheral arterial calcification. That indicates there is a peripheral vascular disease. Especially it is quite common with the diabetic patients. You can see the PTA and the anterior tibial artery calcification. This tells there is definitely a vascular disease. Without going to the Doppler or anything, with the plain X-ray we can say. The second one is just a normal, there is a fracture base, but I want to show the tarso-metatarsal joint. This pointer is not working, but you can see the tarso-metatarsal joint is absolutely normal. So the third one is the diabetic neuropathy. The cursor. So this is the third one. This is the diabetic neuropathy, which predominantly involves the tarso-metatarsal joints. You can see that ill-defined articular. This you can see the normal articular surface. If you see the irregularity, there is a subluxations, there is a sclerosis. That tells it is a diabetic neuropathy. Diabetic neuropathy involves these tarso metatarsal joints or less frank joints more than the ankle joint. I will go to that. This is another subtalar joint and an ankle joint involvement in a neuropathic joint. So these are all the changes that will come little later. Before that, that is the first investigation. That is very obvious, maybe grade 2 or grade 3 diabetic neuropathy. Coming to the Doppler, this is the normal triphasic blow, 1, 2, 3. This is the normal, we do the Doppler. What we are seeing is the continuous wave Doppler, what Sir has shown. And this is the pulse wave Doppler where we can see the same sound in a triphasic pattern. This is 1, 2, 3. If you lose the triphasic, then that indicates there is a disease. So it is a simple Doppler examination then you can do. And for the nerves, there is a, we are doing the shear wave elastography that shows the elasticity changes. There is an increased stiffness within the nerves in the neuropathic affected joints. I think in 1 or 2 years, we will use the Doppler is one of the screening modality, like a nerve conduction study. We can do both nerve as well as arterial in the ultrasound and Doppler examinations. That easily picks up the neuropathic changes. So this is the new parameter under trial, and most of them right now started using this modality. Coming to the peripheral arterial disease, Ravi Kumar sir is going to show, but I will just show only one image. This is a plain X-ray I have already shown, or you can do the CT angiogram. And if the patient is already renal CKD with the diabetic, then we can do non-contrast MR angiogram. If you want to see the vessel, that is an option before going for other modalities. Coming to the topic proper, this is the simple diabetic ulcer. You can see there is an ulcer, there is a subcutaneous pannus or callus. There is no obvious collection, no adjacent bone involvement. Bone is absolutely the normal signal density. Dark means dark, white means white. So there is no bone involvement, no osteomyelitis, simple diabetic ulcer, no abscess, nothing. In this patient, you can see there is an ulcer. There is only the soft tissue abscess. You can see there is a soft tissue abscess. The bone is absolutely normal. So only it is involving the subcutaneous. What is worrying is if it extends to the bone, then it is little, we have to pick up. What is the modalities used? Standard guideline is plain radiograph and the MR imaging. Typically, the diabetic osteomyelitis involve the first metatarsophalangeal joint, the fifth metatarsal head, and the grade 2, and other pressure points. So depending on the deformities and the flat bones, you get all the ulcers. Modalities are plain radiograph and MR is the modality of choice. And when you see a bone marrow edema, even without a cortical break, with an abscess, then you have to think this is a case of osteomyelitis. So I will show one of the examples. Here you can see there is a collection here. You can see the bony changes. The bone is dark here, bone is white. There is a bone marrow edema. So this easily tells it is an osteomyelitis. It is extending up to the bone. You can see here the normal bone is dark and there is an edema here. Entire right grade 2 also shows edema. So this is an osteomyelitis. Another patient, you can see that the bone is destroyed. The normal bones are dark color. You can see the bone is destroyed by an abscess. And you can see the CT, you can see there is a lytic lesions. So if this lesion is in this location, then we have a doubt. It is a diabetic neuropathy or infective arthritis. But if you see anything on the bone, then it is osteomyelitis. If you see in particular tarsometatarsal, there only we have a doubt whether it is a diabetic neuropathy or osteomyelitis. So coming to neuropathic osteoarthropathy, typically involves the tarsometatarsal joint, then subtalar and the ankle joints. In the absence of any ulcer, if you see a swollen foot, then you have to consider the first phase of the neuropathic joint osteoarthropathy. So how to see this? I have shown this normal X-ray. This is a neuropathic joint involving the tarsometatarsal joint. There are 6 Ds are described. You can see the destruction, the density is increased. Compared to this bones, you can see there is a density is increased. You can see multiple debris. These are all because these bones are getting scratched, so you get destruction and there will be a deformity and a dislocation. All this will happen. These 6 D cells, this is a Charcot joint or neuropathic joint. The CT also shows there is a sclerotic area as well as the erosions within the bone. So this is a case of a neuropathic joint. This is a classical joint involvement in a diabetic patient. Until proved otherwise, it is a neuropathic joint infection. The involvement usually occurs in the tarsometatarsal, as I told, or secondly, it can involve the subtalar joint, and rarely it involves the ankle joint. These are all the common joints involved in diabetic neuropathy. So this is the stages of this diabetic neuropathy. The first stage X-ray is absolutely normal because it needs 30% of bone to destroy to see in the X-ray, but clinically the patient manifests as a swollen leg, edematous leg. And in the second and third stage and fourth stage, you can see the destruction, all the neuropathic changes, there will be a subluxation, and the deformity will also occur in the X-rays. The very doubtful imaging where we are also confused is infected neuropathic joint, where there may be an ulcer because of the neuropathic joint. In addition to that infection, then we have to do contrast study. If you see the leading margin which shows enhancement, then it is an infection coexisting with the neuropathic joint. We call that as a ghost sign. And in very doubtful cases, you can do a PET CT that shows again the articular margin. Wherever there is a contrast enhancement, you see there is an uptake, so that we say that there is an underlying infection. So this is the simple normal foot, and this is only the neuropathic joint, and this is only simple osteomyelitis with an ulcer, and there is a mixture of both neuropathy as well as infection together. The important finding to how to differentiate neuropathic joint from osteomyelitis is the joints are involved in neuropathy. Only adjacent bone, that's the subchondral area alone, shows edema in case of neuropathic joint, whereas the entire bone will shows edema in case of osteomyelitis. Cellulitis and diffuse edema will be there, but in osteomyelitis there is a loculated collection and abscess will be there. And subchondral cyst and intra-articular bodies will be there. I told 6 disease that will be disappeared. Once the infection settles, it will destroy all the loose bodies, so you may not see that loose bodies in case of osteomyelitis. I thank you for your kind attention. Thank you very much. So the sir is asking about the deformities, the Charcot's staging. So we have to do the weight bearing flat boot. When the neuropathic joint comes, the arch going for collapse. Then we will take the weight bearing X-rays, the flat foots, the angle. We can do the angle, and that will be corrected. So the flat boot is a manifestation. If it goes excess flat boot, sometimes it will go for the rocker bottom foot, then it will manifest as in ulcer. So we have to prevent the staging of the rocker foot, where we have to do the X-rays. I have not brought that staging X-rays so that we can grade it and we can prevent going for the rocker bottom foot. Before that we can arrest. So it is an ideal X-ray. We can do the angle and we can measure and we can tell it is how much flat foot. It is a normal arch. We can compare with an opposite side so that we can treat the patients.
Whenever there is a less blood flow, we think of cutting the leg off. So we have saved many legs thanks to Dr. Ravi Kumar, who will next talk to us on what to do in critically limb ischemia. And Dr. Ravi Kumar is the first slide. You have a slide? Yeah. Because the CVs they didn't give. Show me the first slide. He is an interventional radiologist attached to Tamburan Center in Ananagar and also Apollo and our hospital. He goes to Bharataraja, goes to several places. He is a consultant interventional radiologist, and he will talk to us on how to save feet with critical limb ischemia.
Thanks, Dr. Vijay. My whole peripheral vascular interventions, I do it only in MB hospital because that's the place where we've got a very, absolute thing how to go over the foot, saving the foot. So in that, I play a role of regaining the vascularity in these peripheral arterial disease patients. So in this lecture, only 2 things, because I'm not going to talk to you on how to revascularize, what wire I'm going to use, what balloons I'm going to use. These are no use to you. Because as a clinician, you need to know, is revascularization important? Or we're just talking just out of here saying, yes, keep revascularizing whatever blocks happening. So that I want to stress upon. Number 2, you see a foot ulcer, you see a wound, and you see decrease in vascularity. Does all these patients need revascularization? So it's a very nice protocol that we follow in MV Hospital. So that I thought it would be useful in the next 10 minutes to talk to you on that. Does revascularization really help? So they compared revascularized with non-revascularized diabetic patient, and it was published in Surgery Open Sciences. There's a 14.94% higher likelihood of experiencing wound healing. So if you choose your patient correctly, and if you subject him to revascularization, be it surgical or endovascular, it increases the percentage of wound healing by 14.5%, which is quite a good percentage. Now endovascular versus surgical, there's always a debate saying what is the best. So lot of trials has been going on through. The latest is the Basel II trial, which they said that let us have endovascular first revascularization. That is, you get a patient and you submit him for endovascular procedure first. Was associated with a better amputation-free survival. The main problem was you need to have at least a 3 to 4 millimeter of the long saphenous vein for a surgeon to take it up and put it up. Suppose, and the cardiovascular surgeon and the vascular surgeon both fight for the same long saphenous, because they want to use it for the cardiac bypass, they want to use it for the bypass here. So if you have a good long saphenous vein which is greater than 3 millimeters or 4 millimeters, it's an ideal case for surgical revascularization. But again, it will be non-targeted. So those are things that we'll be discussing on. So endovascular intervention outcomes, you got whole lot of things like these are straight inline flow. Initially we said single flow maintaining is the best, but then they said multiple level angioplasties. Then later on came the plantar lobe. So many techniques have been described, and each one looks not only at the healing point, and you're also looking at the long-term patency of these revascularization. Okay, so that's how these different technologies and steps came up. So what's new? What we do in MV Hospital? So we quantify the perfusion. So how do you quantify perfusion? I've done Doppler, I've done MR, I've done CT angio. So how do you quantify? So in this quantification, wound blush. So when you have a wound and the Doppler has shown a monophasic wave pattern, decreased flow, the patient is subjected for an angiogram. So in the angiogram, we do the angiogram, there are blocks in it, but you see that the wound is nicely perfused. So that is the sort of wound blush that you're looking at. So it can be as an endpoint of revascularization. When to stop the revascularization procedure? When do I stop? So you do angioplasties and look for the wound blush. So we just show you a couple of examples. Now here, this is okay. You can see that the left hand image shows that SFA block, diffuse SFA blocks. Okay, yeah, here. So no, it's not coming up there. Can you just put that red pointer, please? No, this one. Okay. Okay. See, now this is the entire SFA, which is diseased. You can see there's a complete occlusion, there's a disconnect, and then you can see the infraperpetual flow, which is anterior tibial is fully blocked, posterior tibial is also fully blocked, the peroneal arteries is supplying, and this area needs to be supplied by the medial and lateral plantar arteries. So what do you do? So there is no wound blush at all in this particular image. So this you need to treat. So what we did was, we revascularized. See the whole SFA, the whole occlusion is opened up, and you see this is what I mean by wound blush. You see the area of the wound is nicely perfused when compared to the previous image where there is no vascularity at all. So when you get this to the surgeon feels very happy. Diabetologist says it's good, and the wound will heal much more faster. Now this is another patient which I wanted to show once again, like how bad the wound is, and we revascularize. Basically, we're looking at all these kind of wound blushes. It's a triple vessel runoff to the infraperpetual flow. So now the next question is, can wound blush be used to decide whether patient needs revascularization? It's a very good important point, because you need to know, decide based on wound blush, whether can I go ahead with debridement, hyperbaric oxygen therapy, or whatever therapy you're going to do, or you need to revascularize. So then we extended this. This study is in the process of publication, so I'm not giving you the details of what the whole study shows, We've done around 175 odd patients. And this you see, such a bad wound. And the patient has got an external iliac disease, he's got an SFA disease, he's got only a single vessel runoff, anterior tibial is blocked. In spite of all this, such an amount of good wound blush. Suppose, in case, if you had sent me this case 5 years earlier, I would have said, boss, let's go and open up this external iliac, SFA, put a stent, try and open up the anterior tibial and leave it off. So that was the approach. Now the approach has totally changed. So now this patient, in spite of all these blocks, we never treated him endovascularly or revascularized. We send the patient up for treatment. And this was a wound. And this helped us to say this patient does not need revascularization in spite of the blocks. Okay. This is another example which shows again like gangrene, and you can see single vessel, tibioperoneal trunk off, it's not disconnected, and all these things earlier we were treating. You can see that again there's a good wound blush here. So again, this patient again was not revascularized. So now we don't even do revascularization procedures, we also decide who will benefit from revascularization procedure. So now we've gone to the next step of doing that. And with this, I think I will, quantifying wound perfusion by presence or absence of wound blush on angiogram will not only serve as a therapeutic endpoint, that is therapeutic endpoint, following angioplasty, you show the wound blush and say that this is sufficient amount of wound blush, but it also helps to decide which wound needs revascularization. Thank you.
Dr. Ravi Kumar, there is always a confusion in people's mind about CT angio, MR angio versus digital subtraction angiography. So can you tell what's the difference between the two and which would you prefer as an interventional radiologist?
See, it's a very important question because the clinicians always have this problem as to what to do because so many imaging technologies are there. In case if the patient is having a foot ulcer and the Doppler, the ABA has shown there's a decreased flow, then you immediately go ahead, do a color Doppler scan which shows monophasic wave pattern. So in this patient, I would say, just not because I'm an intervention radiologist, I would say go ahead by doing a digital subtraction angiogram. Why? You got CT, you got MR. See now the patient has got a diabetic foot, non-healing ulcer. And what do? After doing a CT angio, they'll again say heavily calcified because diabetic patients invariably have infrapopliteal calcified vessels. And these calcified vessels, trust me, to do on CT angio is going to be very, very difficult. You can do MR angiogram, but MR, again, we need to do special studies to show the perfusion of the scan. In that, with 30 ml of contrast, be it even a poorly functioning kidney, we get the renal clearance with 30 ml of contrast. I can show you the blocks, I can quantify the perfusion and say, boss, this is what it is. And so now we have started adopting DSA as a primary modality. Once we have known that the patient has got an ulcer, non-healing ulcer, circulation is bad. Suppose if you are in a place where you don't have an easy access to an intervention radiologist, so what do? So at that time you can do, providing the kidney function is normal, you can do, I would still say MR angio will be better than CT angio because calcified vessels are going to be a real problem. So I think this is how we start reclassifying patients on who needs what on what type of imaging. But color Doppler, trust me, is one of the best simple imaging tools to diagnose because it gives you not only the percentage stenosis, it gives you multiple level of stenosis and helps you to guide it properly. So you need to have a good color Doppler guy who can assist you in diagnosing these peripheral vascular disease. Thank you.
Thank you, Dr. Vikumar. I next call upon Dr. Senthil, our diabetic foot surgeon, who's a plastic surgeon by training, and he's going to talk to us on limb salvage.
So when the patient comes to your clinic, you have to assess their gait. So if they come with a foot drop and with a high stepping gait, you should diagnose them with they are having advanced peripheral neuropathy with motor dysfunction. and you have to make them lie down and make them comfortable and expose them adequately. Since it's a workshop, I want to show some other practical points in your clinical practice. Exposure should be up to the knee level, and look for the color of the skin, swelling of the skin, or is there any dermatitis patch sitting in the medial aspect of the skin, because no one can be normal. So no one can have a normal foot in patients with the diabetes. They may have one, two, or more than this complex issue. Probably in my practice, this is the best foot I have seen. So I have seen even worse than this. So they may have so many problems with them, they may not even reveal. So some of the problems may be presenting, some of the problem may be imminent. So once you have a stasis ulcer, probably it will go to a next stage, like a cellulitis or necrotizing fasciitis, like that. So proper clinical examination is important. Look for the color of the skin, swelling, and always look for the interstitial web spaces. And the plantar aspect, look for the cons, calluses, or ulceration. So once you see the ulcer, first you should think why the ulcer has happened in that place. So that solves most of the problems. Okay. So what is the problem sitting underneath the ulcer? That is what our concern. As a surgeon, I want to heal the ulcer. If the patient takes bed rest, probably it might heal. But so everyone wants to be ambulant for their day-to-day living activities. So once they walk again, they'll get an ulcer. So healing of the ulcer is important, and thinking about the recurrence. They shouldn't have the recurrence. So what we can do, that is another question that should be in our mind. So on examination, so you know how to examine the foot, and you should have some biomechanical examination also. And you should look for stiffness in the metatarsal, first MTP joint, and you should look for equinus deformity. So most of the patients may have equinus deformity because of the tendo-Achilles contracture. Because of the chronic and uncontrolled diabetes, hyperglycemia, the collagen metabolism is affected in the patients with the diabetes. They have, wherever the collagen, there will be a problem. So the same thing happens in the blood vessel also. It has a collagen, it gets stiffness in the collagen area. Medial intima thickness is happening there. And the same thing, collagen is more abundant in the tendons, periarticular tissue, bone, joint tissue, and especially in the tendinous part. So as the collagen, metabolism is disturbed, it contracts and the forefoot pressure increases. That's why you can see more of foot ulcers placed in the forefoot. So the underlying pathology also has to be addressed. When you see ulcer, whether it's a grade 1, 2 or 3, that's a practical point you should look for. So how to assess it? So if you try to probe the wound with the blind and probe, if it is not going deep, it's only limited to the skin, it's a grade 1. So you are lucky to have that patient. Patient is also lucky because grade 1 ulcer will give time for them to react. Okay? So our skin is the most antigenic structure in the body. So it gives time. Usually it won't go straight away to grade 3. Patient will have a neuropathy. So they may have deformity, either it's a mild or severe deformity. Then they develop ulceration. So ulcer gives time for them to react, but usually they neglect. They do some sort of dressing and they just simply keep on walking with the ulcer. They proceed it to a grade 2. So grade 1 usually won't get infected. So once it goes deeper structure, once it touches the deeper structures like tendon, bone, joint, then only you see the infection. That's why you see most of the patient will be living with grade 1 ulcer for a long time. Once it crosses the tendon and joint, they'll come to the doctor. Okay? So it's like a sleeping volcano. Anytime it might erupt. So grade 1 ulcer, once you see it, you should see the pathology, underlying pathology, whether it can be tackled with the callus excision dressing alone. Definitely not. We need to give offloading. So my next speaker will elaborate on offloading. Whether it's a local offloading device is alone enough, or we need to do a surgical offloading. So in case of severe deformity, like a prominent first metatarsal head, simply giving a local offloading may not be sufficient. We need to do a surgical offloading, either in the primary prevention or as a secondary prevention once they had an ulcer. In my presentation, I may show some of the examples in that. So my point is, have a clinical examination, inspection, palpation, and as a surgeon, I'm very much interested in looking for the pulse. So the pulse is the passport for me to operate on the patient. Once the passport is not signed, our visa officer is sitting there, so I should get signed. So if the pulse is not there, so I'll get the vascular consent and we do revascularization, then only put the knife on the patient. Because in a dry land, nothing will grow, so in a dry foot also, nothing, no healing will happen. So I'll make sure the wound is the foot is perfused, then only I put the knife on the patient, whatever may be the problem. Okay, shall I start presentation? So biomechanically, you have to look for stiffness in the first MTP joint and ankle. So ankle mobility. So normally they may have a 15 to 20 degree dorsiflexion ankle. That's a normal ankle. If they are not able to do it so, then you can consider the endochlesis is contracted. At the same way, using the goniometer, with the goniometer you can assess the dorsiflexion ankle at the first MTP joint. That's all. So normally it should be 70 to 90. So it should be kept in the plane or the first metatarsal bone. So normally you'll be able to extend from 70 to 90 degree. If it is limited, there is a limited joint mobility, this patient will be prone for hallux ulcers. Okay? So you should look for biomechanical abnormalities. Thank you, sir. I'll go with the brief presentation with that. Slideshow. Next. This one. Won't work. Okay. So we need to have a proper diagnosis. Appropriate investigation has to be done once you see the patient with the diabetic foot ulcer. So infection and metabolic control should be initiated. We should restore the foot perfusion in patients suffering with the peripheral artery disease. That's very important. So wound debridement is done to control infection. Dressing, we have a range of dressing materials during the preparatory phase. And offloading is the key for wound healing. Either even in the post-op period or even after wound healing. Skin cover, we do secondary suturing or grafting or flap form. So once the wound is ready. And the follow-up is most important because recurrence is quite common. So a study showed 50% recurrence in 2 years, 60% in 3 years, 75% in 5 years. So recurrence is very common because we are not treating the underlying pathology. Okay? So once you heal the ulcer, once you operate on the patient, they'll be in the bed rest or they'll follow the offloading protocols sincerely for a couple of months, then they'll forget. Okay? Then they'll again have the problem. So if you are able to correct the underlying pathology, probably the results will be durable. So time is the issue. Patient may delay for seeking treatment, but we should never delay the treatment. This is the common presentation. As you see in clinical practice, the callus and underlying ulcer abscess formation. Callus is excised, ulcer is dressed. The another clinical example, after callus excision, you can see the advanced dressing material. It's not adding up the bulk as you can see it. We can fit into the process. That's the advantage of this kind of advanced dressing material. It has a 5-layer dressing with the non-adherent layer, absorbent, super absorbent, retentive and waterproof layer on top of it with the border adherents. So these kind of dressing materials, so normally 3-layer dressing that makes the dressing bulky, and here this has a practical convenience and the patient compliance is better. Yeah, you have the materials, right? Yeah. Show that material. So this is the polyurethane foam. Yeah. It's a polyurethane. This material is made up of polyurethane foam. It can absorb 10 times of its original weight. So it can absorb as at least 3 pads, how much 3 pads can hold the exudate. That much exudate can be absorbed by this kind of small sheet. Okay, so there won't be any strike through. So normally you put a 3-layer bulky dressing, you can see the wound seepage. So that is a problem. That there will be a spillover of infection, and infection can get into the wound. There is no closing mechanism. So here, since it's a semi-permeable membrane, only the water vapor can go out, but water cannot go in. Okay, so we shouldn't be happy after doing callus excision dressing. The offloading is very, very important, and we should also assess, as I told you earlier, whether this kind of local offloading alone is enough. Okay, so IWGDF guidelines. So I am proud to say our Professor Dr. Vijay Vishwanathan sir is one of the member in the footwear recommendation, offloading recommendation in IWGDF, along with Professor David Armstrong and Sikobus. So they have formulated what is the best for the patient. So when you see an ulcer, don't expect the ulcer to heal using a local offloading footwear. So okay, the footwear may not work. So go for a knee-high processes, knee-high offloading device. Here you have seen a TCC, that's a total contact cost. This cost gives a total offloading, that's nice regional offloading. Patient is allowed to walk, that's a beauty. Okay, if you make the patient lie down on the bed, that will heal for sure, no doubt about it. But he can't be bedridden for all the time, so he is able to walk. So this one is so practical, you can put them on TCC and you can make the patient ambulant for the day-to-day activities. Okay, ulcer heals within 3 to 4 weeks, that is for sure. So once it heals, maybe you can switch over to local offloading footwears. Okay, and still if it's coming, or if you think there is a abnormality underneath, like a prominent metatarsal head, go for surgical offloading. If there is a mild or moderate deformity, so this is sufficient. If the deformity, if you think it is severe, go for surgical offloading, then knee-high offloading device, followed by local offloading footwears. So this is relatively rare, but you do get healed callus with underlying ulcer. The callus excision was done, so ulcer is done. Okay, so dressing is done. So we have a special. So we are strong in footwear manufacturing. Since we have a footwear manufacturing unit, we can design so much footwear for the need of the patient. Here, heel offloading is very, very difficult. So the posterior ortho wedge and all won't be practical. Patient will fall and they'll have a fracture hip. Okay, they'll have a fracture of femur. And this one is nicely designed, and this actually heals heel ulcers, and it gives a nice offloading, and it's very, very good for even preventing recurrence. Okay, now the question comes, where should we do surgical offloading? Okay, now this is catching up. But the problem is people overdo sometimes and they don't do anything at all. So that's not the right thing to do. So offloading, local offloading or regional offloading is must for patients with mild to moderate deformities. Only for severe deformed cases or persistent deformity like tender Achilles contracture or prominent metatarsal head or first AMTP joint restricted movement. So these are the patients will require some form of surgical offloading so that they can have a durable, long-lasting healed ulcers. So understanding altered biomechanics is very important before doing surgical offloading. We shouldn't insult any further. Okay, don't do any harm. Do minimum, because the pathology what you see in a diabetic foot deformity will be complex. It's not a one factor involved. So even in okay. So IWGDF guidelines, what does it say? For a plantar non-healing, non-infected, non-ischemic ulcers. So for plantar ulcers, IWGDF guideline recommends distal flexor tenotomy for lesser toe contractures. Okay, if they have a hammer toe in the lesser toes, you can do a simple needle flexor tenotomy, you can release it. So that that this acts as a surgical offloading. You correct the deformity, okay? So the pressure point ulcer heals. So that's a recommendation. And another recommendation it gives for metatarsal ulcers. If you have a, if you see a metatarsal ulcer with a prominent metatarsal head resection can be done as a prophylactic surgery or metatarsal osteotomy with the offloading device. So this is surgical offloading is not an alternate for local offloading device. That has to be followed lifelong, no doubt about it. This only corrects the excess deformity. Okay. You can see various range of flexion deformity here, clawing of the toe, and you can see the mallet hammer toe deformity. Interestingly, polysyndactyly also you can see in this picture. So the toe tip callus or ulceration can be relieved by simple needle flexor tenotomy. You won't even see the needle puncture site. So it releases the toe from flexion deformity and pressure is relieved. Another clinical example, you can see hammer toe deformity involving lesser toes, and especially the third toe had an ulcer that got infected. You can see the local cellulitis picture also. Distal phalanx got infected. We had done tenotomy and sequestrectomy. You can see the deformity corrected picture. They won't have the ulcer forever, at least in the toe tips. That guarantee we can give for them. This patient came with equinus deformity with a non-healing ulcer, tried with the many local flaps and many other local procedures, not work, and we had done percutaneous tender Achilles lengthening procedure along with the TCC. It healed nicely. So this will be the commonest presentation you'll be seeing. Patient will get ulcer healed, and again they'll come with the ulcer. So here the problem is not the ulcer. What is thing behind the ulcer? The big thing is back. What is the big thing? It's a head or the first metatarsal. So you can see in this picture, the first metatarsal head, because of the chronicity of the ulcer, it produces some periosteal reaction, periosteal bone formation. It has become bulky. Okay, so that metatarsal head got resected here, and you can see the nicely flush out of the surface and the plantar aspect. There is not jetting out on the first metatarsal head. So the same way in a Charcot foot, patient will have a exostosis under the non-healing chronic ulcer. The exostosis was removed, the excess bone was removed, and wound healed nicely. Then of course we have to give them local offloading. But this kind of picture, no? So with the local offloading device, very difficult to heal this kind of ulcer and maintain the healed ulcer. So we had to do the correct the problem underneath. So this is what happens if you don't do offloading, surgical offloading device. As you can see here, the pointer is working. Yeah. So this patient had a 4-foot ulcer over the first metatarsal head here. This got healed. Patient got happy probably. So, but actually what happened? This ulcer penetrated inside. It infected the bone. You can see the destruction of the bone. Okay, that has given relative offloading. Okay, so that bone, that bulged bone dislodged because of the fracture, pathological fracture, because of the osteomyelitis. So the pressure got relieved. So this ulcer is healed. So patient is under the false impression. So ulcer is healed, but it erupted there in the top and the side. Okay, this is what happened if you don't do surgical offloading like a metatarsal head resection in these kind of patients. Okay, here we had to do sequestrectomy. Yeah, we are done. We have removed that infected thing. Okay, infected metatarsal head. So advantage of doing surgical offloading in this kind of patients, probably you can save the toe. This patient luckily came with the toe intact. We were able to save the toe. You can see the healed big toe. Okay, big toe matters a lot. Small toe maybe we can sacrifice, but big toe it matters a lot. Once the big toe is gone, half of the foot is gone. So it triggers a series of events, and slowly, one by one, the problem will keep coming again and again. Okay, so that is why we insist on surgical offloading in some of the patients, selected patient, not for all. And we had to do here in this patient, interestingly had a peroneal overdrive. So the peroneal tendon, which is there in the lateral compartment, it actually attaches to the base of the first metatarsal. Okay, it acts as a flexor of the first ray. So this can be easily tested by,
Slides.
as the patient push the front foot.
Other slides. Slides.
If I have time, I will continue, otherwise I will finish this slide.
I had to go down.
Yes, sir. So this problem is the peroneal overdrive. You can ask the patient to push forward. So only that head of the first metatarsal will be pushed in the front when compared to this area. So this is called peroneal overdrive. We have done a peroneal tendon transfer, peroneus longus to peroneus brevis. So ulcer is healed. Okay. So thanks for the opportunity. So thank you all.
Thank you, Dr. Senthil,
Thank you.
for explaining all the new procedures as a surgeon to save the foot and offloading also, surgical offloading also. I next would like to introduce Dr. Basab Ghosh from Tripura, Agartala, Tripura, who's come all the way from Tripura to talk on offloading and rehabilitation. So it's not enough if you cut off the leg, you should look after the patient after the patient's leg is cut off. So Dr. Basab Ghosh is going to talk to us on that.
Offloading. Thank you, organizers, Trek 2024, for giving me the opportunity. And special thanks to Dr. Bijay Viswanathan sir for putting me in his elite group of diabetic foot. My topic is offloading and rehabilitation in diabetic foot. We heard full session of diabetic foot, but I am starting from the basics, A, B, C, D. If we see the pathogenesis of diabetic foot, neuropathy in diabetic foot, there is motor involvement, sensory involvement, and autonomic involvement. And because of sensory involvement, there is loss of sensation, which is causing the direct damage to foot infection, leading to infection, gangrene, amputation. Then comes motor neuropathy. Motor neuropathy is causing high plantar pressure through small muscle atrophy. There is intrinsic minus foot due to imbalance. There is subluxation of foot, my previous speaker was mentioning. And then comes autonomic neuropathy. Autonomic neuropathy due to reduced perspiration, there is callus formation, and that also causing high plantar pressure. And then in autonomic neuropathy, there is increased blood flow, which is causing bone resorption and ultimately Charcot deformity and high plantar pressure. So evidence says peripheral neuropathy affects around half of all the foot of diabetes and leads to loss of protective sensation in the foot. And if you see it in the schematic diagram, I made it simple. Because of sensory loss, there is increased chance of diabetic foot ulcer. When there is added elevated peak plantar pressure, the chance of diabetic foot ulcer goes double. When there is barefoot walking, inadequate facilities for diabetes care and education, and poor socioeconomic condition, with this etiology, this study is done by none other than Dr. Bijay Viswanathan, there is added chance of diabetic foot infection. When there is added mechanical stress, the chances goes much higher. What is mechanical stress? Mechanical stress is composed of plantar pressure which are accumulated during repetitive cycle of weight bearing activity. But the moment we are putting mechanical offloading, the chances of diabetic foot ulcer is reducing by many folds. So offloading plantar pressure is the key strategy. So far we heard from all our speakers, offloading is the key strategy for the prevention and also healing of neuropathic ulcer. My previous surgeon speaker was talking about offloading in the treatment purpose, and it's also important for prevention purpose. In people with neuropathic diabetic foot ulcer, multiple interventions are typically required for effective healing, including local wound management, infectious management, revascularization, and pressure offloading. And out of that, first three are the surgeon's choice, but knowledge of pressure offloading is very important for the diabetologist to contribute to better patient care. Here we are standing with the diabetic foot management. And education of offloading is must from day one. How? The best advice is ideal footwear in the day one on the consultation. This is another study by Dr. Bijay Viswanathan. This is a beautiful study. A sample of 241 consecutive diabetic patients attending the foot clinic with previous foot ulceration and also those considered at high risk of foot ulceration were included in the study. And group 1, group 2, group 3 and group 4. 4 groups divided. Group 1 was given sandalwood made of MCR. Group 2 given with sandalwood insoles of PU foams. And group 4 with deformed foot were given modulated insoles. And group 4 kept with their own footwear in containing leather board insoles. And all patients received educational guideline. They are checked for bioasymmetry. They are checked for peripheral vascular disease with the ABI index of less than 0.8, and dynamic plantar pressure was evaluated. And follow-up was done after 9 months, and the same parameters were measured after 9 months and recorded for all patients. And the patients who were using therapeutic footwear showed lower foot pressure, while those who used the non-therapeutic footwear showed an increased foot pressure. It's a very important finding. And the occurrence of new lesions was also significantly higher in patients in group 4 who were not using therapeutic footwear. So the reduction of plantar pressure with the therapeutic footwear in a 9 months period clearly highlighted the benefits of using soft, shock-absorbing insole materials and correctly designed footwear in diabetic patients. This footwear is never ideal for diabetic patients. Sandalwood thong, they damage the motor nerve and they don't have support, so limited joint movement is not been covered. So ideal footwear is PU soles, that is the polyurethane soles with extra depth for effective pressure offloading, and the specially designed insole, bed and foam layer for adding offloading purpose. So the non-weight bearing is the easiest way of offloading in day-to-day practice, what Dr. Senthil was telling. So those are bed rest, then crutches, then wheelchair and all of that thing. And Andrew Bolton repeatedly stated that it is not what we put on a diabetic foot ulcer that heals it, rather what we take off from the wound that heals, that is offloading. This is an international working group in the diabetic foot, has been published every 4-year guidelines, and it was established in 1999. Professor M. Viswanathan from Chennai was the founder member or one of the founder member, and presently Dr. Bijay Viswanathan is one of the active member in that. So we are proud that Chennai is taking the lead in diabetic foot. The 2019 guideline is on the use of offloading intervention, and Dr. Bijay Viswanathan was part of that, and every year they are giving updates. Of that guideline, it said non-durable knee-high offloading device is the first choice. Using this device, there is a total contact cast or non-durable knee-high walker, what Dr. Senthil was telling for treatment point of view. So TCC is the gold standard for offloading device, diabetic neuropathy. Approximately 80 to 90% pressure reduction has been observed in studies with TCC. Removable knee-high offloading device is the next choice, where TCC is not been used or contraindicated. And removable knee-high offloading device is another choice when knee-high offloading device is contraindicated. But we must remember we should encourage the patient to wear the removable device at all the times. Instruct the patient not to, this is the 4th recommendation, instruct the patient not to use conventional or standard therapeutic footwear as offloading purpose, unless none of the above mentioned device is available. So it may not be the choice, it has to be the compulsion, it may be the compulsion. If none of the above mentioned 3 offloading devices available, consider using felted foam in combination with appropriately fitting conventional standard footwear. So those are the non-surgical offloading devices available, the traditional TCC, then roll-on TCC, then removable foot, then crow foot, then orthostatic wedges. So this is the things are available. And regarding surgical offloading, the guidelines said in 2019, if non-surgical offloading fails, they recommended the consider of surgical offloading. So non-surgical is the first choice, then come the surgical intervention for healing of metatarsal head and digital ulcers. What Dr. Senthil was repeatedly telling, metatarsal is very important. And what are the points? He has given in details, but I am giving in one slide because I already covered everything. So callus removal is there, then condylectomy, then pen condylectomy, Achilles tendon lengthening, then surgical correction of skeletal abnormalities, then plantar fat pad augmentation. Those are the surgical intervention for offloading is there, and those are the surgeon's cup of tea. We are just helping them by sending the patients and helping the patients. Callus is a thickened area of keratinized diffuse plaque commonly found in areas of high plantar pressure. It acts as foreign body, and as there may be pre-ulceration or ulcerative lesion hidden below the callus, because the callus is putting around 500 kilopascal pressure. And recently, Caroline Abbott in Manchester, she said that more than 4.1 kg per centimeter square peak plantar pressure is the threshold. So callus is putting much higher pressure than the threshold. So those are the callus removal I did in my clinic myself. So little bit scalpel use I do for the patient's benefit. Offloading, we must remember, once an ulcer is formed, studies describe that unless the ulcer area is offloaded, healing may be chronically delayed, even in an adequately perfused limb. So offloading is very important. Also, you must remember, once ulcer is healed, the job is not finished. The risk of recurrence is very high, as 80% in a median 4 months, showing the need of continuous offloading in diabetic patients. So offloading from day 1 to last date of the breath. This is for the regular prescription. This should be the regular practice for diabetes patient. This is the next part of my topic, rehabilitation. Actually, I have given 2 topics, offloading and rehabilitation. So I said 10 minutes, it's not possible. So I was told that I will be given extra few minutes, maybe 5 minutes I am getting extra. Patients are often referred to rehabilitation facilities at later stages of the diabetic complication, particularly after amputation surgery, but that not to be done. Therefore, rehabilitation needs to be more involved in the management of diabetic foot and should be in all stages of diabetes care. The role of rehabilitation in the management of diabetic foot can be divided in 2 parts. One is pre-wound rehabilitation and another is post-wound rehabilitation. So regarding the role of rehabilitation in the risk of diabetic foot, how it helps, what are those? Aerobic exercise, muscle strengthening exercise, balance exercises, and flexibility exercises. So any exercise we are prescribing our patient, they are actually rehabilitation. Rehabilitation term is nothing different. We are always talking to our patient regarding rehabilitation. And the main goal of exercise prescription is to prevent new wound in the contralateral side. Remember, contralateral side is very important. Once right foot, so left foot may get affected. So encourage them for rehabilitation. And to help glycemic control, to prevent the side effects of immobility and the accelerate the healing of the wound. In particularly diabetic neuropathy, how rehabilitation exercise is improving? They improve by microvascular function and increase fat oxidation. Like this, they are helping in diabetic neuropathy also. And how they are helping in vasculopathy? See those points minutely. Physical activity can reduce the risk of diabetic foot by increasing tissue perfusion. Studies indicated that walking and intermittent walking, that is very important. Patient is complaining, I cannot walk. Wait, then again start walking. This intermittent walking improve the walking speed and thus reduce the risk of vasculopathy related diabetic foot ulcers. So we must remember what the contraindications of exercise. Several points are there: hypoglycemia, RNAs, blood sugar more than 250 with ketones, and very important I found, proliferative retinopathy patients should not do exercise vigorously. Vitreous, same like for vitreous bleeding, severe hypoglycemia within last 24 days. So those are the contraindications you must remember before prescribing. So joint stiffness, my previous speakers were giving much emphasis on joint stiffness. Diabetic patients have an increased connective tissue thickening and stiffness in all of their main tendons and ligament. This is clinically relevant, particularly in the foot-ankle complex, as it leads to abnormalities in plantar pressure distribution. So it's important. So how? Later extremity stretching exercise for preventing diabetic foot ulcer is very important, those type of exercises. Actually, with prescription, I prescribe in my clinic how to do exercises by stretching ankle, then doing again, then stretching knee in the wall, putting the other legs in straight. So those are the ways. Then plantar fascia stretching and myofascial release techniques are also very important. For that, here it is shown, the ball is shown. I ask my patient, you put some rough surface in the floor, then you roll your foot for small muscle exercises like this. And it's very, very important, very, very helpful. Many of the patients are coming to our clinic with foot pain. You just check the shoe, whether it is soft insole is there or not. Then I ask for warm water foot bath and small muscle exercise, and it gives miraculous result. Initially they think this doctor does not know anything, is not writing any medicine, but later they will appreciate you too. So those are the way foot and ankle range of motion exercises are for diabetes with and without diabetic foot ulcer. Once the patient is having foot ulcer, during foot ulcer, so this type of exercise helps in vascularity and helps in joint mobility. So our ankle is having 4 movement, right, flexion extension, then right left, then rotation, 2 sides. So this 4 movement can be done. The role of physical therapy modalities, out of that, the most commonly used is electric stimulation, ultrasonography, and phototherapy. And studies have shown there is no superiority among each other. All are more or less together. And remember, once ulcerated diabetic foot ulcer recurrence rate is 40% within the first year, and up to 65% after 5 years of post-healing. So once surgeon is treating the patient, job is not finished. Might be his job is finished because the patient will come back to the diabetologist, but our job is to encourage them, treat them for recurrence, to prevent recurrence. So take home message, patient should be educated not to walk barefoot at any time. Ideal shoe should be covered shoe for better protection to external injury with comfortable toe box, soft insole for pressure distribution with rigid counter back for lack of joint movement, limited joint movement protection. Regular callus removal should be planned by a skilled healthcare professional. Then relieving pressure by offloading an ulcer should always be the part of the treatment plan. And coordinated team approach has shown to decrease the frequency of limb loss in diabetes. Thank you. So this is actually daily foot examination is very, very important, and thanks for your patience hearing.
Nice talk, Dr. Basapko, sir. Is there any questions? If there are no questions, we can wind up this session. I can call upon...
Thank you.
Yeah. You stay there in the stage, sir.
It's because
get a moment to,
there are no questions. I will request you, sir, to kindly honor the guest with the mementos. Dr. Ravi Kumar. Sir, please, anybody can do. Dr. Amarnath. Dr. Sendil. And Dr. Sendil. Dr. Sendil is there? Okay, yeah, sorry. So thank you, all the speakers. It was a really very wonderful workshop.